my job to end out day 2 is to give you a little bit of an overview of our new membership site, data tools, and resources. We'll also have another session like this tomorrow that will be co-moderated by Dr. Jennifer Taylor and Mike Hartnett on our team. So I'm going to start out with just a few reminders about the NBSTRN. So as you heard on day 1 from Dr. Molly Manier and Dr. Melissa Parisi on the NICHD team, NBSTRN is part of the Hunter Kelly Newborn Screening Research Program. And this graphic is just a reminder of some of the priorities of the NICHD as it relates to newborn screening research. So one of the areas is to identify, develop, and test screening, both screening and diagnostic technologies to help develop treatments and intervention strategies for conditions that are either already part of routine newborn screening or conditions that are candidates for newborn screening. Another area that NICHD focuses on through its efforts and funding research projects is to help to generate and provide the evidence base for conditions that are under review by the advisory committee. And as you know, NICHD, as we just heard from the Emory team, plays a really important role in supporting pilots of conditions that are either recommended for nationwide screening, are candidates, or have recently been added to nationwide screening. These are just some of the sort of shorthand summary of some of the projects that NICHD is currently funding. So you heard from Dr. Ingrid Holm earlier about genomics and the use of genomic information in the newborn period. You heard from Dr. Kathy Swoboda about natural history studies and looking at health outcomes of conditions that have been recently added to newborn screening. We just had a great discussion about newborn screening pilots, especially pilots of recently added conditions like Pompe, MPS 1, and XALD. And my job today is to talk a little bit about the Newborn Screening Translational Research Network. So the NBSTRN is a key component of the Hunter Kelly Newborn Screening Research Program. And this was awarded to the American College of Medical Genetics and Genomics in 2008 as a contract. And we've been fortunate to lead that contract since 2008. And we are just in the middle of our 13th year developing tools, resources, and expertise related to newborn screening research. So today I'm going to talk a little bit about a new membership site that we were working hard on last year. So it's amazing that we're able to accomplish what we have and that we're actually have a product to show you. And we're excited to get your feedback on our new tools and resources. And so we've had a heavy focus on updating and actually creating some new data tools and thinking through some resources that we've actually gotten requests to develop by the newborn screening community. We have a few new exciting things to announce. So all of our tools and resources related to the NBSTRN are now in a cloud environment. And we're actually able to leverage a really innovative and forward-looking program at NIH called NIH Strides. And so what that provides us is expertise across to NIH as they work to move researchers and other groups to utilize a cloud environment, both for primary data collection and for data storage and sharing. While we were developing our new membership site, we also underwent a multi-month process to achieve an authority to operate a FSMA moderate cloud environment. So what that means, having the FSMA moderate designation by NIH, is that we're able to collect identifiable data. So as you've heard from many of the research teams over the last 2 days, being able to collect things like dates of birth, visit dates, all those kinds of things that qualify under personally identifiable information is very important to help us understand longitudinal data. So we're very excited to have achieved an ATO. The ATO is good for 3 years. And so for us, the clock is already running to be able to show how we're going to utilize that really great designation and resource. So we have several tools that we have just launched. So you can log in at mbstrn.org. And we've reminded you during this research meeting to sign up. Most of the resources on the website are available without signing up, but we really encourage you to sign up to be able to interact with the NBSTRN team, our teams of researchers, and our expert working groups and our steering committee. So only by signing up will you be able to access their expertise. As we thought through developing this new membership site and a revamp of the data tools and resources, we really had to think through what are our goals and work with Dr. Parisi and her team at NICHD to think through what would be of use to the research community today. And so our goal, as you heard on day one, is really to facilitate research with the goal of improving health outcomes of newborns with genetic or congenital disorders. And the way that we do this at NBSTRN is by designing, delivering, and really enhancing newborn screening resources and tools that are available broadly to the newborn screening community, but mostly with a focus on research. You heard from our partners at APHL New Steps earlier today, and there's logical handoffs from the research that we help facilitate and the great work that they do to implement newborn screening for new conditions and for conditions that have been around for a while. NBSTRN benefits from a 12-member steering committee, which is currently co-chaired by Dr. Ingrid Holm and Dr. Susan Berry. We're really lucky to have their ongoing expertise and advice as we design and build these tools. We also have 6 expert work groups that help guide our efforts, and each of them are focused in a different area, so we can call on them as we need different types of expertise. In designing the new membership site, we really had to do some planning. So I've always been taught in IT that a big part of what you do is requirements and use case generation. So we spent a lot of time. Many of you on the line helped us go through some storyboarding and some other activities to really prioritize what we were going to design, develop, and ultimately maintain on our website. So, just to back up, what informs our efforts are really the key components of newborn screening, beginning before a baby's born with that interaction between prospective parents and their physician. So, we know that education begins early about newborn screening. And then we understand the parameters of neonatal screening, whether they occur in the birthing hospital or at the newborn screening programs that are based in the states and territories and the District of Columbia. We always think of newborn screening as being this multi-component, multi-stakeholder system where there's a series of handoffs from the prenatal time point, the newborn time point, to when the newborn is positive and goes through a series of short-term follow-up testing, and then ultimately is referred to a clinician or a subspecialist for diagnosis and ultimately for clinical care and management across the lifespan. So all of these key components of newborn screening, as well as the fact that there are almost 4 million newborns screened every year in the United States across 53 different newborn screening programs, that really helps inform what we design and do at the NBSTRN. Taking that a step further, we break it into these different components and think through what are the key parameters that really inform research, from screening to diagnosis to treatment, and then really the ultimate goal of newborn screening is to save babies' lives, but also to document that early identification led to a benefit. So we've been taught that a lot through the advisory committee and the evidence review. So a lot of the research that we support and facilitate has as the ultimate goal being added to the recommended uniform panel and to realize nationwide treatment for improvements in health outcome. We have a lot of decades of expertise that have really informed our work, both in starting in the 1960s with screening for just one disorder, over here in the upper left with PKU. And now we know, as we total up all of the conditions across the United States, that there are screening for over 80 conditions, not in every state, but some states screen for all of the conditions that are part of the routine or recommended uniform panel, as well as some conditions that are mandated through legislation. We can also be informed by the types of screening technologies over here, where we began with just one type of screening technology, and now we have a whole menu of different technologies that are utilized. We're also informed in our efforts by the types of clinical interventions and management strategies, whether it's in the early days, medical foods and diet treatment, to now we have stem cell transplants, gene targeted therapies, and many other types of interventions, as well as many more different medical disciplines. So not any longer a metabolic geneticist, but now we're working with, as you heard from Dr. Swoboda, with neurologists, Dr. Jennifer Puck with immunologists, hematologists. We've got all these clinical specialties to think about. So ultimately, this expansion of newborn screening has really informed our work at NBSTRN as we generated this new website. We know that the hallmarks of newborn screening expansion are really built on evidence generation. So this is just a little schematic of cystic fibrosis, where you can see over time survival from the 1950s all the way to this graph ends in 2005, but you can see the steady improvement in survival times because of the management strategies. And now we know that with cystic fibrosis, there's even the opportunity, depending on the genetic variant and the change, to actually intervene and hopefully correct some of the impact of those variants. So in thinking about this evidence generation, and then that's what researchers are all about in newborn screening, we look to the work of the advisory committee and we look at what they consider when they're looking at adding a condition to nationwide screening. So whether it's information about the incidence, about a prospective pilot, about a case definition, about treatments, and the intricacies of lifelong management, those are all things that help inform the tools and resources that we've built into our new membership site. So I cannot emphasize enough that this nomination process of systematic evidence review really does inform what we do. So we think about each one of these parameters really informing research and informing the tools that we are developing. So I'm going to start out today with giving you a little tour of two of our data tools. I'm going to talk about the Longitudinal Pediatric Data Resource and the Newborn Screening Virtual Repository of States, Subjects, and Samples. Dr. Taylor will focus on the MBS Conditions Resource tomorrow. So we've worked hard over the last year to update each one of these tools. The Lpdr, many of you have heard about case studies using that over the last few days. The MBSVR is really a revamp of what was formerly called the Virtual Repository of Dry Blood Spots. And then we created this MBS Conditions resource that, again, Dr. Taylor will highlight tomorrow. So I'm going to start out with the Lpdr. And just a reminder that, as I said, we did achieve authority to operate. So this is especially important for the longitudinal pediatric data resource, because this means that we are able to collect data over time, and we're able to collect, if consented and if the IRB approves, personally identifiable information, which makes our job of data analysis over the long term much easier. We've heard from our speakers earlier today and yesterday on the value of collecting data over time. The majority of newborn screening conditions require lifelong care and management. So although newborn screening saves lives, not most of the conditions are not curable, but they are treatable. So by collecting information over time, we're actually finding out about that benefit of early identification and treatment through newborn screening. This is a snapshot of the updated longitudinal pediatric data resource. And I just pulled out a few case studies. This is looking at sickle cell disease, and this is a project funded by HRSA, and it's called the Sickle Cell Disease Newborn Screening Longitudinal Follow-Up Program. This is an effort that actually enables community health workers to enter data into the Lpdr in a de-identified fashion. They're working with individuals who are identified all the way from the newborn time period all the way through enrolling through adulthood. This is a very large study. I think the last time I looked at the numbers, we were over 8,000 subjects in this study. And what they're looking at is improving access to care over the lifespan and characterizing the medical home for these individuals. So you might think, well, gosh, this doesn't sound like it's generating evidence for newborn screening, but it really is. It's beginning to talk about how we make sure that individuals from across the United States have access to the most appropriate and the optimal medical care so that everyone can achieve the best outcome. If you look at the early publications of the advisory committee on long-term follow-up and longitudinal care, that was really the main goal, is so that everybody who's identified through newborn screening has the chance for an optimal outcome. Another case study you heard a little bit about from Dr. Holm earlier today was one of the cohorts that was part of NSIGHT called BabySeq. So BabySeq was an effort out of Boston Children's, and this is where they looked at both healthy and NICU cohorts. Dr. Holm has really been a leader in working with the NBSTRN and enabling us to really try out some of our use cases of not only collecting phenotypic data, but also collecting genomic data, and then thinking through how to share it and how to use it to answer new questions. Now I'm going to give you a little bit of a tour of the updated VRDBS. So we decided at the end of our 10 years of running NBSTRN, we took a look at the VRDBS, and we really did a lot of interviews with researchers who use the tool and thought through what are the key parameters that they really wanted to know, essentially when they're working with state newborn screening programs. And so we created an expansion of the VRDBS into a repository that not only looks at storage of dry blood spots, but also talks about the policies of each state newborn screening program, and talks about where you can find potentially subjects and samples that are characterized for different diseases. And so we really expanded the resource into focusing on the data that we think researchers are interested in, and that we've actually heard from researchers that they would like to be able to understand about the newborn screening programs around the United States. You all are very familiar with the advisory committee's efforts at the federal level to create a recommended uniform panel, but you also are aware that each state, territory, and District of Columbia makes their own choices for which conditions to screen, how to conduct screening, how long to follow screen positive cases, whether and how to store dry blood spots. all of those things have an impact on research and the ability of researchers to conduct and think through different types of investigations. So this is a screenshot of the MBS VR, which shows implementation across the United States. This is an interactive tool that we hope will facilitate research. And by that, we mean it'll give, whether you're a researcher, a parent, an advocate, or a state newborn screening program, it will help you better understand policies and procedures within your own state related to research and screening, and let you look nationally at different screening and to answer and ask different questions. So this picture shows a national view and shows, using these colors, how many conditions each state screens for. So you can see the yellow state screen for 40 or less. We know that, just counting up conditions can be an area of hot discussion in the newborn screening community, and that APHL is actually leading a work group to look at what's the best approach to counting conditions. But this is our best guess at how many conditions states report out based on our work with the individual states, as well as mining the data graciously provided to us by APHL New Steps Data Repository. So some of the types of questions that you're able to ask and answer using this tool are things like, which kinds of conditions are screened in each state? What's their nomination status? So meaning, is it part of the recommended uniform panel? And if it is it a core condition or is it a secondary condition? You can also visualize candidate conditions. So Dr. Wilcox and Dr. Taylor were talking about, sort of what's that list of conditions that are on the horizon for consideration for nationwide screening. Well, we actually keep track of some of those conditions and states that are screening for them. And you can do a filter on this map based on those types of questions. So there's a lot of different use cases that you can look at using this tool. And we think it'll be really helpful for researchers to get to know the individual newborn screening programs, where they can go for different types of information, and will just help accelerate their research efforts. Now I'm going to step back before I actually do a live sort of little tour of the website and look at a few more pieces of the website or key components. So I focused so far on these data tools, but now I'm going to talk a little bit about our resources. And so if you go to our website and you click on the resources tab, you can learn more about our steering committee and our expert work groups. As I said, we have a 12-member steering committee. We're always looking for new individuals to join that steering committee and our work group. So if you would like to nominate yourself or one of your colleagues, feel free to reach out to us at mbstrn@mbstrn.org. That's an email address. You can also read about LC Advantage. We're actually undertaking an update to LC Advantage, and we'll preview that at our September Newborn Screening Virtual Summit. So we'll have an interactive tool that will be readily available in September for to look at the ethical, legal, and social issues in newborn screening research. We have a series of information and tools under a newborn screening pilots resource tab. So this is where we keep track of things like the Duchenne muscular dystrophy pilot that you'll hear about from Mike Hartnett tomorrow. We track some data dashboards every month as the newborns are enrolled in this project and look at the early results. So this is one of our sort of ways to use a research study to plan some new data tools that will be available to the whole community in its next generation. And then finally, we've got the National MBS Pilot Webinar that many of you participate in every month. And this is run by Dr. Jennifer Taylor, and she'll give you highlights of that part of the website and that particular tool and resource tomorrow. We also have another tab on the website that details who we consider the community or the network of NBSTRN. Now, if you don't fall into any of these 4 groups or you fall into all 4 of these groups, that doesn't mean our network is limited to just these sort of umbrellas. We welcome stakeholders from all across the research community, as well as in the ethical, legal, social issues, really anything you can think of that's sort of tangentially related to pediatric and newborn research. But we have here a focus on researchers, healthcare professionals, families and advocacy groups, and state newborn screening programs. Our focus on families and advocacy groups is something that's always been there as part of the NBSTRN network, but it's becoming increasingly important to us and to our team. We have seen over the years that the role that families and advocates play in expanding newborn screening and advocating for research dollars is nothing short than of amazing. And so we want to make sure that we're building tools and resources that can help families become involved, whether it's to nominate a condition for nationwide screening or to conduct and be part of longitudinal studies that help inform health outcomes across the United States for any condition. We also have another tab on the website that looks at the latest news. So Dr. Ki Chan, who's behind the scenes running this meeting for us today, has joined our team over a year ago, and since then has really built out a phenomenal group of tools and resources to help us get our message out. And so so I encourage you to check out the different segments of the news. We routinely do blog posts, we have events, and we like to market our partner events because there's always something going on related to newborn screening research that we want to make sure that our network is aware of. And so now I'm going to go back to the 2 data tools that it was sort of my job today to talk to you a little bit about: the longitudinal pediatric data resource and the newborn screening virtual repository of states, subjects, and samples. And so I'm going to go into the website really quickly, if I can find the right button. And so so I am already logged in. So let me just log out. And so this is what any of us can see if you want to navigate along with me to mbstrn.org. On this upper navigation bar, you can see, if you hover over, you can see all of the different resources and tools that are under each of these different headings. If you look at the data tools, you'll see a little lock signal or symbol by the Lpdr. That means to access the Lpdr, you have to sign up. Or if you're already signed up, you have to sign in. And so if I wanted to go to the virtual repository of state, subjects, and samples, I'm able to do that without logging in. But if I want to go to the Lpdr, it's going to ask me to log in. And so the sign up process is very easy to do. So I would encourage you all to do it. Some of the things that I couldn't show you on sort of the screenshots before is the way that we can use the Lpdr to interact with some of these data sets. As you heard from all of our speakers, from Dr. Parisi to Dr. Swoboda to Dr. Holm, it's really all about enabling that primary researcher to conduct their study, but then also to take in the data, whether it's phenotypic or genomic, and to enable secondary use of that data. And so we have 7 featured studies. Each of these featured studies, if I click on it, has anywhere from 4 to 6 different data visualizations. And these visualizations are meant to describe the data sets so that if you are interested to learn more about the types of data that might be available for secondary use for BabySeq, you could take a look at these pictures and you could understand a little bit more about their cohorts. There's either graphical representation or the same information presented in a table. Sometimes there's pictures like with this word cloud, or again, a graphical representation or a table. And again, this is meant to give you a high level description of the types of data that might be available in the study. In what we call the demographics details table, this is actually a case level de-identified data that you can download. And so I can go down to the bottom of the page and I can download this page of information. And so if I wanted to begin to think about, do I want to apply to use this data and ask new questions of the data? You're able to download the data and start to think through that. Now, the case level data that's de-identified is only meant to describe the study. It's not the wealth of information that's available through this project. You can learn more about the other types of data that was included and that would be available if you apply for it by reading more about this study under About This Study tab. So here you can see all of the different types of study questions that the BabySeq team asked, and you can even download in a spreadsheet their data dictionary. So let's say you wanted to do the same type of an effort as the BabySeq team, you can actually look at, this is their actual data dictionary. And so you don't have to reinvent the wheel, so to speak. You can see the types of questions that they asked and answered throughout their study. You heard from Dr. Holm that they used HPO terms, but in addition to the HPO terms, they also asked and answered several different types of questions. Now, if I go back to the Lpdr and look at the other featured studies, you also heard from Dr. Kathy Swoboda. This is the Project Cure SMA project, and then we have the SPOT SMA project. Both of those projects' data, although they're still recruiting subjects and enrolling subjects, is available if you want to apply and look at the data and learn more about the data. One of the goals, as Dr. Swoboda said, is if somebody other than herself and her team start to use and apply for this data. Similarly, you can download some demographic information. This has actually 700, a little over 700 cases. Not only can you download the question and answers that Dr. Swoboda is using, you can download it in a REDCap format. What that does is that enables you to take the REDCap formatted data dictionary, which has some extra columns in it, and you can upload this into a REDCap project, and right away you would, at the click of a button, have a case report form where you can then start to collect information. So you can see over here, there's a little summary of the study questions that Dr. Swoboda's team is asking about each of these individuals. And again, you can read more about each of the projects. We feature all of these different studies because they're ones where the data was relatively easy to de-identify and to create these downloadable forms. So this is Dr. Sue Berry's IBMC project. That was a 10-year natural history study that is still ongoing and is still enrolling subjects through the regional genetics networks. But as far as this data set, this is about 380 MCAD subjects. You can see which ones were identified through newborn screening or family history. And again, you can look at a de-identified case level data set. You can look at a REDCap formatted data dictionary so that you're able to replicate her study if you would like to. In addition to the featured studies that each have, case level, de-identified case level data and pictures, we've got this list of additional studies. So these are all studies that are either have not yet shared data with us, or ones that are currently being planned and are actively collecting data. So each one of these we anticipate will be moved to a feature study and have more information attached to them as they mature a little bit. The other tool that I wanted to take a little bit of time to review with you is the MBS Virtual Repository of State Subjects and Samples. And again, we really met with researchers and thought through what kind of information do they want to know about state newborn screening programs. So one of the key questions that individuals or researchers want to know is how many births per state, and how many conditions are they screening for? And so this is actually a two-part tool. There's a table at the bottom that's filterable and downloadable. And then there's a map that gives you some visualization at the top. They're not connected with each other. So if you ask a question of the map, it doesn't necessarily update the table at the bottom. And so this is meant for visualization, and the table below is meant, again, to be able to download information. And so let's take a look at one of the questions we get a lot is how do newborn screening programs how long do they save their dry blood spots? And so with that filter, I'm able to now look across the United States and look at which states retain dried blood spots longer than a year. The yellows are less than a year. So if I hover over, you can actually see the number of years. But if you were a researcher and you wanted to do research on very old dry blood spots, or you wanted at least them to be stored for 10 years, you could then hone in your sort of efforts to outreach and work with the states that store them that long. If you were going to be doing things like DNA-based analysis, you might want to look at states that store their dry blood spots at -80. So we understand that -80 with a desiccant is the best way to store dry blood spots for genomic analysis. And so again, this is a visualization to really help states hone in on the types of information that they may be interested in. You can also look at whether states report that they conduct long-term follow-up. And so the states that report that they conduct long-term follow-up might be a place that you might be able to collect some clinical data and some outcome data and augment that with your own longitudinal data collection efforts. Moving from the map down to the table, you can click on each one of these column headings and actually sort the information based on what you might be interested in. So if I want to look at the states that keep dry blood spots for the longest period of time, I could sort that table, and then I can go down to the bottom and I can download this information. Now, this little tool might seem pretty simple, but this is one of the key questions that we get a lot from researchers is how long do states store dry blood spots? How long, what conditions do they screen for? What policies do they have about accessing dry blood spots? So all of this information we think will give researchers and research teams sort of a leg up in their work with newborn screening programs. And so we hope that you'll take the time to really dive into each one of those tools. You can actually also, instead of doing a national view, I can pick a particular state. I always pick Texas because it's my favorite. Dr. Friedenberg is probably on the line. So she's been great with sharing information. So if I click on Texas, then I can get some more detailed information on their program. I can also get the number of births and the breakdown on race and ethnicity. I can look at expected cases. Now this is based on literature. I can look at the types of screenings that Texas does versus the national picture. So this looks at RUSP classification for screenings, and you can see nationally there are 35 core RUSP conditions and how many Texas says that they screen for and count. Again, this information we know will have to be updated over time, and we'll work with the state programs to make sure that it's as accurate as possible. But again, we hope that this tool is not meant to replicate the great work that APHL New Steps does on their repository, but also to just focus in on what we think researchers want to know from each of these state programs. And so I just want to end today with saying that whether you're interested in joining one of our expert work groups, or if you have an idea for one of our data tools and how we could expand it to be more useful, feel free to reach out to us at mbstrn@mbstrn.org. Please follow us on social media. And again, I just want to, before we take questions and answers, thank our funders at NICHD for all their support and advice in building this new membership site and really helping us hone in on the kinds of things that we think researchers will find useful as they help work with us to expand newborn screening research. Thank you. And with that, I'll take any questions that you guys might have. Hi, Dean. The state-by-state data is available in a table format. So if you dive in and look at, the tool, if there's any information that you can't download in a table, just feel free to reach out to us. We're always excited to expand the utility of these tools and make sure that they're super useful for everybody. One of the things that we really are going to be focusing on this year is really the secondary use of data. And so Dr. Holm talked a little bit about the NSIGHT cohorts. And so we're actually restarting a work group that she chairs so that we can execute some of the use cases that are part of the longitudinal pediatric data resource. So in thinking about how do we get people excited about using our tools and resources, we can begin as a team to develop these use cases. So we can think about looking at things like the clinical relevance of variants for newborn screen conditions using longitudinal clinical data. So in Dr. Berry's IBMC 10-year natural history study, they have a lot of genotypes and they have a lot of longitudinal data. So that's sort of a win-win to put variant information and couple that with clinical information and try to look at, then you can look at online resources like ClinVar and ClinGen and see if these variants have been characterized as pathogenic or likely pathogenic. So we're working on some analysis in a paper related to that kind of work right now. We're also going to be working with the NSIGHT team to combine their cohorts based on some commonalities across the data set so we can increase the statistical power to ask and answer some of the research questions. And then here I just highlight some of the questions that we have heard from researchers that they want to know about subject samples and policies at the state programs. So I'll wait just a minute to see if there are any other questions. If there's not, feel free to log into the website to sign up. If you have any ideas for us, or if you'd like to join any of our work groups, or have any advice for us on any of the types of tools, any expansions of the tools, just feel free to reach out to us. Great. Thanks, Carol. So now that we've got the website built, there's lots of ways we can improve it. So we really want you guys to bang around and to send us in information and feedback. And with that, I will give you guys back 15 minutes to your day and close out day 2 of the 2021 NBSTRN network meeting. We're looking forward to rounding out day 3 with a series of great talks, and we'll end up with another interactive training with Dr. Jennifer Taylor and Mike Hartnett tomorrow. Have a great evening, everyone. Thank you.